So which of the following statements about CCTGA is true? CCTGA is relatively rare lesion, accounting for 5% of all congenital heart disease. 5% of CCTGA have situs inversus. Recurrence risk in the first degree relatives is 15 to 20%, and 50% have dextrocardia. So you can write the answers in the chat box. Okay, Dr. Amol, yeah. So that's right. So can you say how many percent? How much percent of CCTGA accounts of all congenital heart diseases? So you're right. The right statement is B. So why is A wrong? So CCTGA accounts to 0.05% of all congenital heart diseases. What is the recurrence risk in first degree relatives? Anyone? Dr. Saurabhi, Dr. Amol? Yeah, that's right, 2 to 5%. And how many percent have dextrocardia? So approximately 25% of the patients would have dextrocardia. Okay, coming to the next questions. All of the following about CCTGA are true except L-looping of the cardiac tube is primary pathologic feature of CCTGA. Malalignment of interatrial and interventricular septum is one of the central features of CCTGA. There is a presence of aortomitral continuity, and LVOT is deeply wedged between the right and the left AV valve, resulting in high probability of LVOT obstruction. So which of this following is true? And all of these following are true except. Very good. So, yeah, the right answer is C. The right answer is C. So there is actually pulmonary because there is it's usually associated with transposition of great arteries. It is associated with pulmonary mitral continuity and not aortomitral continuity. Okay, and if you see the primary pathology in CCTGA is after the L-looping, because of the L-looping of the ventricle, there is malalignment of between the interatrial septum and interventricular septum, and this is the one which gives rise to most of the complications associated features with CCTGA, like a presence of VSD and the LVOT obstruction. So the most common lesions associated with CCTGA are VSD, LVOT obstruction, tricuspid valve abnormalities, and RVOT obstruction. So Amol says A. So VSD is commonly associated with CCTGA. Can you tell me the percentage? Approximately how many percentage of CCTGA would have a VSD? So approximately 80% of the patients would have VSD. What about LVOT obstruction? So 30 to 50% would have LVOT obstruction. How many have tricuspid valve abnormalities? Tricuspid valve abnormality is actually the most common anomaly which is associated with CCTGA, and it is present in approximately 90 to 95% of the patients, and RPOT obstruction is usually rare. So what is the usual pathological reason for LVOT obstruction in CCTGA? It is usually muscular, secondary to wedging of the LVOT in between the left and the right AV valve, fibrous tissue derived from the membranous system, tissue tags from the right and left AV valves, and or all of the above. Right, all of the above. Right, all of the above. So usually there is wedging of the LVOT, as we said before, between the left and the right AV valve. There is fibrous tissue, and which of them is the most common? Which of them is the most common? Amol says muscular, secondary to wedging of the LVOT. Not really. Actually, the tissue tags and accessory tissues from the right and the left AV valves are the ones which usually cause obstruction in the left ventricular outflow tract. Next question is about coronary artery anomaly in CCTGA. The following statements about coronary anatomy in CCTGA are true except in situs solitus with CCTGA, the coronary arteries follow a mirror image branching pattern. Single coronary is the most common coronary abnormality. Proximal coronary artery pattern at the aortic sinus depends upon the aortopulmonary rotation or the aortopulmonary relation, and the peripheral coronary artery pattern depends upon the apicocable ipsilarity. So which of this following is? All of this following are true except. So right, so Amol is right. Situs solitus with CCTGA coronary arteries follow a mirror image banting pattern. So they come from the posterior facing sinus, the right and the left. The right facing sinus usually gives rise to the coronary artery, which bifurcates into the left main and the circumflex, and the left coronary artery, the artery rising from the left facing sinus, would give rise to the morphological right coronary artery. Most commonly, this is associated, coronaries associated with CCTGA are normal. If there is an anomaly, then single, so 76% to 80% of the times, the coronary artery abnormality is, coronary artery features are normal. If there is an abnormality, it's usually a coronary artery which is crossing the RVOT, followed by the single coronary artery. And the proximal pattern, coronary artery pattern, would depend upon the aortopulmonary rotation, and peripheral would depend upon the apical. So this is what we see in CCTGA. This is the L malpose aorta. So the coronary arteries arise from the facing sinuses. The right facing sinuses gives rise to coronary artery, which divides into the circumflex and the left, and the left facing sinus gives rise to the morphological right coronary artery. So the incidence of conduction tissue abnormality is less commonly associated with CCTGA with intact ventricular septum, CCTGA with large VSD and severe PH, CCTGA with subpulmonic VSD and severe PS, or CCTGA with VSD and pulmonary atresia. So Amol says CCTGA with intact ventricular septum has the least common conduction tissue abnormality. Anybody else? So what is the reason for the conductive tissue abnormality in CCTGA? Why does conduction tissue abnormality are associated with CCTGA? Why is there high incidence of complete heart block in CCTGA? So actually, if you see, as I said before, there is malalignment between the interatrial and the interventricular septum, and this is because of the faulty looping of the ventricle of the cardiac tube. So if the distance between the atrial septum and the ventricular septum is high, there is high incidence of conductive tissue abnormality. So now what happens in the presence of VSD and presence of LVOT obstruction, the distance between the interatrial septum and the interventricular septum progressively decreases. With increasing severity of the pulmonary stenosis, there is progressive decrease in the malalignment of the interatrial and interventricular septum. So CCTGA with intact ventricular septum would have the highest incidence of complete heart block, whereas CCTGA with VSD and pulmonary atresia would have the least incidence of complete heart block, and remaining all would fall in between. So the answer here would be D, where CCTGA with VSD and pulmonary atresia would have least association with conductive tissue abnormality. So the following ECG features are seen in CCTGA. In atrial situs solitus, the PVM morphology is normal irrespective of the AV discordance and the cardiac position. Absence of Q waves in the right precordial lead and complete heart block is seen in approximately 10% of the patients at presentation. B and C are true, or all of the following are true. So Amol thinks that only B and C are true and A is wrong. Anybody else? So actually all of these statements are true, and the P-wave morphology is actually dependent upon the atrial solitus, situs, and it is not dependent upon AV discordance or the cardiac position. So if there is atrial situs solitus, the P-wave morphology is absolutely normal. As we all know, there is absence of Q waves in the right precordial lead, and 10% of the patients present with complete heart block. So if you see this ECG of a patient with CCTGA, there is presence of Q waves in lead 3 and in lead AVF, and in lead V1, whereas there is no Q wave in V5 or V6 as is normally seen in normal individuals. So there is absence of Q waves in the left precordial leads, presence of Q waves in the right precordial leads, and the presence of Q waves in lead 3 and lead AVF. So what do you see in this X-ray? So what is the thing which my pointer is pointing at? So the pointer is here. Can you see the pointers? Here. So what does this X-ray show? So the X-ray shows cardiomegaly. Sorry. The X-ray shows cardiomegaly. There is normal pulmonary blood flow, but this is an unusual shadow which is seen on the X-ray. Anybody can tell me what is this shadow? And in consideration with CCTGA, what do you think this shadow is? So this is the shadow of L malpose aorta. So if you see this kind of X-ray with this huge shadow over here, the first thing you have to suspect is an L malpose aorta. Now L malpose aorta can be associated with many lesions. CCTGA is one of the most common lesions which it is associated with, but it can also be associated with DORV and other congenital abnormalities. So this is the one which is showing L malpose aorta. So which view will you use in the cardiac cath lab to best profile the interventricular septum in CCTGA. Either it is anterior posterior view, sorry for the spelling mistake there, right anterior oblique with or without cranial tilt, left anterior oblique without cranial tilt, or D. So in which view would you best profile the interventricular septum in CCTGA? So Amol thinks it's right anterior oblique. So why do you think it's right? You're partly right. Right anterior oblique will show the interventricular septum better, but which is the best view to do that usually? So if you see the interventricular septum in CCTGA, it is because of the faulty looping. The interventricular septum is placed more horizontally or sagittally, and actually the anterior posterior view is the best. And if not the anterior posterior view, the next view will be right anterior oblique with or without a cranial tilt. So if you see this angiogram, your AP or AP with cranial view would best show your interventricular septum. So you see this interventricular septum is intact in this patient. So this is a retrograde angiogram from the aorta. So this is the L malpost aorta going into the right ventricle, and this is an injection, and we can beautifully, the interventricular septum is beautifully seen. This is not seen in the patient with a normal heart. In a normal heart, the interventricular septum is more oblique. So that is why you have to use left anterior oblique view to profile the interventricular septum. However, in CCTGA, you can use the AP view and the AP cranial view, which will give you the best profilation of the interventricular septum. Coming to the next question, survival in CCTGA is in CCTGA is best in patients with no associated lesions, tricuspid valve abnormalities, presence of VSD with or without PS, and prognosis is not dependent upon anatomic variations. So what do you think? So we can actually make this into two questions. One is which is the best prognosis, and one is which is the worst prognosis. So which is the best prognosis? Amol thinks there is no associated lesion. Which is the worst prognosis? So actually Amol is right. The best prognosis of CCTGA is associated with no associated lesion, and the worst prognosis, yes, that's right, Amol. And the worst the worst prognosis is associated with tricuspid valve abnormalities. Amol was saying VSD with or without PS, but the worst prognosis is associated with tricuspid valve abnormalities, and the best prognosis is with no associated lesions. And this is as seen in this Kaplan-Meier chart. The two groups of patients, one is with associated malformations, and the second is with no associated malformations. If you see the median survival in the first group is approximately 40 years, whereas median survival in the ones with no associated lesion is approximately 60 years. So the prognosis is best in the patients with no associated lesion. If there is tricuspid valve abnormality, the prognosis is even worse. Question 12. All of the following are treatment options of CCTGA except physiological repair, double switch repair, PA band, Pastille, and single ventricular palliative surgeries. So the question is except. All of the following are treatment options for CCTGA except. So physiological repair, among things, physiological repair is not a treatment option. Well, it is not a preferred treatment option for sure, but it is definitely a treatment option. Double switch is the most preferred option. PA band in patients with intact interventricular septum and AV valve regurg, and rastally repair. So rastally alone will not be useful in patients with CCTGA, because if you do just a rastally repair, that is root the LV to the aorta and put an RV to PA conduit, what will actually be converting a CCTGA physiology into a TGA physiology. So rastally repair has always be associated, has always should be done with Sennings repair. So it should be Sennings plus rastally repair and not rastally repair alone. So the answer to this question would be D. So in presence of systemic AV valve regurg, all of the following are true except PA band improves the ventricular function and AV valve regurgitation by mechanism involving septal shift or by altering the pulmonary blood flow, and the PA band should be deferred until systemic ventricular dysfunction sets in, and systemic AV valve regurg is the single most important factor which is associated with poor outcomes in CCTGA. So all of the following are true except. So if we go into these options one by one, PA band improves ventricular function and AV valve regurgitation by mechanism involving septal shift. So what happens in and this statement is true. What happens in CTJ is there is because the right ventricle is a systemic ventricle and the LV is the subpulmonic ventricle, there is a shift of the septum towards the LV. So the LV becomes D-shaped and the RV becomes round. However, this is now not what it is meant to be. The anatomy and the physiology of the right ventricle is meant to be a subpulmonic ventricle, and when there is a septal when the interventricular septum shifts into the left ventricle, there is dilatation of the right ventricle and there is leakage of the systemic AV valve. So when we do a PA band, there is increase in the LV pressure. This pushes the ventricular septum back into the right ventricle and helps in better functioning of the right ventricle as well as the functioning of the tricuspid valve regurg. PA band definitely improves the loading conditions of the heart by altering the pulmonary blood flow. So it would decrease the improve the RV function and decrease the systemic AV valve regurg. PA band should not be deferred until systemic ventricular dysfunction sets in. In fact, as soon as we notice that there is some leak in the tricuspid valve, we should send the patient for PA band. And systemic AV valve regurg, as I said before, is the single most important factor associated with poor outcomes in CCTGA. So the statement which is wrong in here is C. PA band should be done early. We should not wait till the systemic ventricular dysfunction sets in, because once the systemic ventricular dysfunction sets in, then the prognosis becomes really guarded. So all of the following about double switch operation is true except LV as a subsystemic ventricle is less likely to fail, better long-term outcomes as compared to physiological corrections, less likely to develop arrhythmias, and abnormal coronary artery abnormality is a relative contraindication for double switch operation. So let's go into each of these. So definitely, if we do a double switch, the left ventricle will be the subsystemic ventricle, and the RV will be the subpulmonary ventricle. We are giving them what outputs they're supposed to do in a normal individual, and hence they would be less likely to fail. Definitely, they have better long-term outcomes as compared to physiological repair. Because we do Sennings in double switch operation, they are more likely to have arrhythmias, especially sinus node dysfunction and atrial arrhythmias. And abnormal coronary artery anatomy is a relative contradiction for DSO. So the answer here is less likely to develop arrhythmias. In fact, they are more prone to develop arrhythmias. This is my last question here. The fetus with CCTGA can present with hydrops due to complete heart block, systemic AV valve regurg, subsystemic ventricular dysfunction, or all of the above. So answer was very quickly given by Amol. So yes, it is D, and all of these can cause systemic ventricular dysfunction. So complete heart block can in turn cause systemic ventricular dysfunction. Systemic AV valve regurgitation by itself can cause hydrops fetalis, and later can lead to ventricular dysfunction. So all these factors would lead to development of cardiac failure in the fetus, and the fetus would then present with hydrops fetalis. Thank you.